2 pills, a small plastic cup, $25. The factory that pressed those tablets got paid 3 cents. Somewhere between the loading dock and your hospital bed, someone collected the other $24.97. And it wasn't your doctor. The question is who? And the answer involves more middlemen than a used car lot. Start with the pill itself. Acetaminophen, the active ingredient in Tylenol, is one of the most mass-produced chemicals on Earth. It is synthesized in bulk, mostly in factories in India and China, for somewhere between 1 and 3 cents per standard tablet. The raw material is coal tar derivative. The process is decades old. There is nothing exotic here. A bottle of 100 pills at your pharmacy costs about $8 retail. That math is not an accident. So, the drug is cheap. Genuinely, structurally cheap. And yet the moment that same pill crosses into a hospital, the price can jump by a factor of 800. Hospitals charge anywhere from $8 to $50 per tablet, depending on the institution and the insurance situation. $25 is not the extreme. It is closer to the average. Here is where the machinery starts. The first layer is the hospital chargemaster. Every hospital maintains a master price list, thousands of line items, each with an assigned charge. These prices are largely fictional. Nobody actually pays chargemaster rates except, crucially, the uninsured. For everyone else, the number is a starting point for negotiation. But here's what they don't tell you. The higher the chargemaster rate, the more the hospital can claim it discounted when dealing with insurers. A $25 pill discounted to $12 looks generous. A $3 pill discounted to $2.80 does not. The fiction has a function. The second layer is the Group Purchasing Organization, or GPO. These are companies that sit between hospitals and drug manufacturers and supposedly negotiate bulk discounts. Sounds like it saves money. The catch is that GPOs are largely funded by fees paid by the manufacturers themselves, typically 2 or 3% of the contract value. So the entity negotiating on the hospital's behalf is being paid by the company the hospital is buying from. The conflict of interest is not hidden. It is the business model. Follow the money past the GPO and you hit the distributor. Companies like McKesson, AmerisourceBergen, and Cardinal Health sit in the middle of nearly every drug transaction in America. They buy from manufacturers in bulk and sell to hospitals and pharmacies. The 3 largest distributors collectively handle roughly 90% of all pharmaceuticals sold in the United States. That is not a competitive market. That is a bottleneck. And bottlenecks charge rent. Each of these layers takes a margin. The manufacturer takes 3 cents. A markup gets applied through the distribution chain. The hospital then applies its own markup, partly to cover the cost of storing, dispensing, tracking, and administering the medication, but partly because it can. A hospital pharmacist pulls that pill from inventory. A nurse carries it to your room. That labor is real. But the accounting systems bundle it into the pill price rather than the service charge, which is how a tablet becomes a line item worth $25. Then comes insurance, the layer that makes the whole thing nearly impossible to read from the outside. Your insurer has a negotiated rate with the hospital, say $14 for that same pill. You may owe a portion of that, depending on your plan. But the negotiated rate is confidential. The hospital is not allowed to tell you what your insurer pays. The insurer is not advertising it either. What you see on your explanation of benefits is a number that has been processed through at least 3 separate pricing decisions, none of which were made with you in the room. There is also a less discussed mechanism called a spread. Pharmacy benefit managers, PBMs, are another middleman layer that manages drug benefits for insurers. When a PBM processes a drug claim, they sometimes pay the pharmacy or hospital one rate and charge the insurer a higher rate. They pocket the difference. That gap is the spread. It is legal. It is common. And for years, it was not disclosed to the employers and insurers who were effectively being charged it. Some states have now mandated transparency. Most have not. What about generic acetaminophen versus branded Tylenol? At the hospital level, almost none of it is branded. The pill in your cup almost certainly came from a generic manufacturer. The Tylenol name is irrelevant once you are admitted. What matters is the NDC code, the National Drug Code, which determines how the hospital bills it and how the insurer reimburses it. The brand is theater. The billing code is everything. Here is what the $25 actually breaks down to in rough terms. Manufacturing, 3 cents. Distribution margin, maybe 30 to 50 cents depending on the drug and contract. Hospital markup for handling, labor, and overhead, the bulk of the remainder. But that overhead includes the cost of uncompensated care, patients who cannot pay, which hospitals legally must provide and financially must offset somewhere. Your $25 pill is also partially subsidizing the person in the next room who will pay nothing. The system is not entirely cynical. It is a broken mechanism that produces a cynical result. And the people running these systems are not villains in the movie sense. Hospital CFOs face enormous pressure. Margins at most non-profit hospitals are thin, below 5% in a good year. The chargemaster inflation, the GPO arrangements, the opaque insurer contracts, these evolved because each solved a short-term problem for a specific player. Nobody designed the Rube Goldberg machine. They just kept adding parts. So here is the counter move, the thing you can actually do with this information. First, always request an itemized bill. Hospitals are required to provide one. Billing errors are extraordinarily common. Studies suggest they occur in up to 80% of hospital bills. A charge for a medication you refused, a procedure billed twice, a room rate overlap. These are not rare. They are routine. An itemized bill is the only document that lets you catch them. Second, if a bill looks wrong or unmanageable, negotiate. Hospitals have financial assistance programs, charity care, that most people never hear about because hospitals are not required to advertise them aggressively. A number you cannot pay is not necessarily a number you owe in full. Medical billing advocates exist specifically to fight this. They often work on contingency. They take a cut of what they save you. They know the codes. They know the rates. They know what the hospital actually accepted from your insurer, which is public information in some states now. $25 for 2 pills is not a glitch. It is the machine working exactly as it was assembled, layer by layer, margin by margin, over decades. The 3-cent pill is not a scandal waiting to be fixed. It is the baseline from which every other number is constructed. Now you have seen the construction, and that is the only leverage the system was never designed to give you.